Firstly, a big welcome to you all to Clear Week, and thank you for joining us. So this is our first session of Clear Week for 2023, and a great deal has actually happened with the programme since we last did this 18 months ago. So 33N developed the CLEAR programme, so clinically led workforce and activity redesign programme with Health Education England back in about 2017-2018. And since then, we've completed more than 40 projects across a range of different NHS priorities, including urgent and emergency care, elective recovery, primary care, mental health, and ophthalmology. During this time, we've also had more than 100 staff leading change using the CLEAR approach and the methodology. And when you include our CLEAR courses, we actually have more than 2,000 clinicians and managers who now have an understanding of the CLEAR methodology. So a huge amount has actually been achieved in this time. Clear Week, which is this week, is all about showcasing the work of frontline staff who've been leading the CLEAR projects, whilst at the same time caring for patients at an incredibly difficult time for the NHS. So it'll be a chance for you to connect with others and share learning on the projects, which have a focus on supporting the NHS, both in transformation and recovery, and taking forward the aims of the NHS long-term plan. So if you haven't already, please do have a little look at the programme for the next 5 days on the CLEAR website and sign up for further information and share with colleagues who may be interested. But to kick off with our first session, A Taste of CLEAR, John, Jeans and I will both be taking you through a CLEAR approach and give you some background on the programme. As I say, it's a very much an interactive session, so there'll be polls coming up for you to also contribute. And we'll take you through the 4-stage process, asking you some questions along the way. We're going to be recording this session so that we can share it on our website and with those who haven't been able to make it. So just to make you aware of that. So just to get us started then, I'm going to introduce John, who is the CLEAR programme lead. And he's going to take us through initially a little bit of background about CLEAR before we get into the interactive part of the session. So over to you, John.
Thanks very much, Alex. Good afternoon, everyone. My name is John Jeans. I am an anaesthetist in London, and when I'm not anaesthetising, I lead the CLEAR programme nationally. The next 2 to 3 minutes are just going to give everyone here a bit of background about the CLEAR programme, what it is and how it aligns to the NHS goals and priorities that we have in the long-term plan. So, CLEAR. CLEAR stands for Clinically Led Workforce and Activity Redesign, and the purpose of the programme is to empower staff to use a combination of big data analysis and qualitative techniques to redesign models of care and workforce to improve patient care and outcomes. The way that this is done is either by doing projects or education, and this is all of the projects and education are underpinned by a 4-stage methodology, which starts with clinical engagement, then moves on to matching that using something called an inductive thematic qualitative analysis, or that's what the academics call it anyway. And that inductive thematic qualitative analysis draws out key themes from having conversations with people. Those key themes are then aligned to big data analysis, and that big data analysis, which we'll give you a little bit of a glance from later, enables you to understand what is true and present in the data, and what matches the themes that have been found from speaking to colleagues that work across different professions in a healthcare organisation. Finally, there's an innovation phase where the people participating in the CLEAR programme come up with new ways of working, new models of care and new models of workforce to tackle the challenges that they've evidenced, and then before modelling up a series of recommendations, coming up with an implementation plan for how to implement those changes to improve patient care. Next slide, please, Alex. As Alex said, the programme we've now done over 40 projects, I think it's 43 now, across the country, across a range of different clinical themes. I'm not going to read out all the different themes down the side, but they range from urgent emergency care to primary care, ophthalmology, and elective recovery. The program itself started in 2019. The first projects were done in 2019, and those projects in urgent emergency care. And then after taking a brief sojourn to support with the COVID response and critical care, the program's then grown further to look at different clinical areas across the country. Next slide, please. So the aims of the program are to create a clinically led culture that builds new skills and new ways of working, excuse me, that provides clinical ownership for change within the NHS. And the reason for having these aims is that one of the things that we know is that if we have a clinically led and operationally owned projects that are building skills in people, that are engaging with colleagues about the new ways of working that we're actually going to deliver, we will get that clinical ownership from across a range of different professions, which makes it far more likely that any outcomes from the change are actually realised across the NHS. So those are why the aims of the programme sort of exist. If we move on to the next slide, please. And so what the projects and education of the program do is that they improve recruitment and retention by placing clinicians at the heart of decision making or transformational change within their organisations and systems, but also building and developing portfolio careers that make the NHS a more attractive place to work. There's also the programme supports in the transformation of delivery to manage demand more effectively, and that is obviously a key priority given all of the challenges that we know that we're all facing in our day-to-day practice. And by transforming delivery to manage demand, there's therefore an enhanced access to services. But most importantly for me, and this is something that is very, very close to my heart, because one of the reasons I got involved in this space is because my dad got pretty, well, didn't get the kind of care we'd want our patients and colleagues to get. And where his care fell down was when he was transferred from different services across the system. And so one of the key things that CLEAR does is promote collaborative working across organisations and systems, because we know that that's going to have real tangible benefits for colleagues and staff across the country. Next slide, please. This is a overview of all the different facets of the programme, and I'm not going to sit here and read them all out because they are legion, but just to sort of put a couple of draw a couple of key points. CLEAR is a NHS programme that's hosted at East Lancs Hospital Trust, and has input or commission from various different parts of the NHS. And the key things that the programme does is, as we've already said, support recruitment and retention, empower staff to do innovative redesign of care in a way that trains and upskills, and also builds a wider community of practice through the NHS by using novel software and empowering colleagues to use new tech. So that's, I suppose, the key highlights to take away from here. Next slide, please. So without further ado, I'll hand over to Alex, who will go through a little bit of a mini CLEAR project. Yeah, over to you, Alex.
Thank you, John. So we decided that actually the best way to really give you an idea about what CLEAR does and what a project entails was to actually try and involve you in the short period of time that we have. So we've got an interactive taste of CLEAR, which ideally will take you through some of the questions around that four-stage methodology, from clinical engagement, data interrogation, a little bit of innovation, and some recommendations. And we're going to try and do that within the next 20 to 30 minutes. The first bit is that essentially, well done everyone. You've all joined the CLEAR programme, you've had your induction, gone through some training, and there's an excellent project immediately available for you to get involved with. That project is going to be held at a hospital that we've called the CLEAR Hospital, and it's going to be in the emergency department there. So the project's around urgent and emergency care. So this is where the interaction bit comes in for you. So I think Suman is going to post a poll in the chat in a second, which will come up. And what I'd like you to do is answer the question of what you would like to know about the hospital before you start. So just type away anything that you think you would like to know before starting this project? Anything at all? Can see Toby, you're frowning at the screen, thinking away. Excellent. So I'd like to know the staffing model, size of the hospital, patients, number of patients, yep. Probably the number of patients that it serves. Types of specialist units. Well, yeah, A&E, what kind of A&E it might be. Number of beds, the key issues, yeah, what people think about the hospital, any information you can get about the hospital before going there. Special measures someone's put in very helpfully. There's always a CQC report about any hospital, so there's loads of sources of information we can get that are publicly available. Retention levels, so thinking certainly about staffing, giving you an idea about what staffing churn looks like. The CQC report's down there, yep. Challenges faced currently. Yep. News about the hospital, yeah. So even kind of locally reported news, or sometimes more nationally reported news. Certainly, we've worked in hospitals where they're hitting headlines nationally as well. Health inequalities, someone's brought up, which is an excellent thing we can have a little look at, about the kind of area, the population that it serves, what that area looks like, access to the hospital. So many, loads and loads of questions, and actually loads of sources of information that we can tap into before we even set foot there, and really, really helpful to get some of these bits of information down. Fantastic. So I'm going to close that off now and give you a little bit of information about the hospital. So some of this you've asked for, and some of the questions we'll still need to find more information about. So in terms of the Clear Hospital, they've got a Type 1 emergency department. So that means it's got consultant-led 24-hour service and full resuscitation facilities. It serves a population of 500,000 with an average of 200 attendances per day. And certainly from the conversations that you've had and what you've seen coming out of the different reports you've read, you know that there's an increase of attendances to hospital, particularly post-COVID. You know that there is departmental overcrowding and probably delays in getting care. Suboptimal experience for patients. You may have found that in either the local news or commentary on the kind of hospital website. Difficult working environment for staff with challenging recruitment and retention. So some of these things you may be quite familiar with in seeing in the news at the moment anyway. So certainly loads and loads of information that we can get even before starting the project. And it's useful to get that kind of context before going in. The next thing that we really would like, given that context, given that you've started this project and you're thinking, I've got a 6-month project, we're going to try and make some changes. The next question we really ask is about impact. So we normally go through this question with the client, but also the key people in terms of leadership at the hospital as well, but also with our team as well, as to what impact would you like to achieve with this hospital. So I'm going to ask you all to have a think about that and put down the impacts that you think you would like to achieve through doing this project. What would you like to get to as an endpoint? Patient satisfaction, certainly, and patient care. A change in waiting times. Happy staff. Excellent. Equality of service. Yeah, so particularly thinking about the health inequalities and access to care. Potentially a change in attitudes. We want to explore a bit more. Patient outcomes. Appreciated staff, certainly. Meaningful improvement. We tend to try and look at this when we're going through it with with the different stakeholders, we do tend to have a look at what are the patient outcomes that we really want to, or the patient impact that we really want to achieve. How do we know that we've achieved that? What are the measures that we can then look at and say, actually, we want to achieve something quite measurable and specific? So we try to break these things down, particularly thinking patient level outcomes and what we can achieve there, but also then thinking workforce outcomes. What can we achieve there? How can we measure that? And then thinking about things like system level outcomes. How, if any organisation does not necessarily stand on its own, it stands within a collaborative system. How do we know that those connections are being made and that communication and support is happening? So we try to break down a lot of these impacts and articulate them as early as possible so that we know how to design the project to achieve the impacts that we want. So certainly all of these things would fit into those kind of categories: the patient category, workforce, system, and organisation. Brilliant, thank you. So I'm going to close that one off there. And so you kind of outlined a little bit of information about the hospital. You've outlined what impact you want to achieve with the project to try and help gauge how you're going to then deliver the project. So that allows us to move into the first phase of this four-stage methodology. As John was saying, the clinical engagement phase is where we gather as much rich kind of qualitative data about the service as possible, and this involves talking to as many people as possible. So before you actually start going out and talking to people, what we like to do is think about the patient journey, how the patient would move through an area, for example, the emergency department, and all the different organisations and individuals that they will meet along the way in that patient journey. That will then help understand all the different stakeholders that we need to talk to as part of this project. So with that in mind, the next question I have for you is, who is it important that you talk to? Given, thinking about emergency departments, thinking about if you've attended one as a patient, your journey through it, who is it important for this project that we talk to? Excellent. Yes, a porter, because they are often not people that are spoken to about change, but have a lot of information because they move in and out of the department and have often been there a period of time and can kind of see different departments and the issues there. Receptionists, cleaners, certainly streaming navigators, the patient, receptionists, ambulance teams, yeah, nurses, therapists, bed manager, triage, social workers, certainly, diagnostics, site lead, family members. Yes, all levels of staff, certainly. Head of department, definitely. So as I say, that the important thing about this is not only is getting that information and making sure that we capture information all the way along the patient journey. So thinking about how patients get into hospital, if they're coming for a same day or urgent treatment care at hospital, how are they going to get into there? So all of the avenues of referral into the hospital, all of the mechanisms of getting to the hospital, then how they move through that department and the staff involved and interacting with that, and then how they actually leave the hospital as well. So thinking about care planning beyond hospital and beyond discharge. So the idea is to talk to as many of these people as possible and gather their perceptions of care and the way in which care is delivered, and their perceptions also of the challenges that are really faced and the barriers to delivering ideal patient care. It's also really important, it kind of serves two purposes, not only just giving us that information, but it really is key in kind of developing the trust that is between the project team and the people on the ground. Because really, the idea of the project is to be the kind of voice of those individuals, to try and make sure that their voice is heard in any recommendations that are made, and also through that process getting their buy-in for the recommendations at the end. So it's developing that trust and really understanding, giving them a kind of space to talk about the issues that they really feel are the pressing ones. It's also key, as someone has mentioned, in terms of talking to the kind of heads of department, it's key to involve people from different levels. Because what we often find is that although people will potentially speak in different language or raise slightly different things, when we've triangulated the information, we're actually realizing that we're looking at the same challenges and issues just from different perspectives. And so it's really valuable taking that time to go through and talk to as many people as possible. One thing that's been mentioned here that we don't actually do is talk directly to patients. And the reason for that is because of the potential difficulties with speaking to patients and the vulnerability that that puts them in potentially with the change, thinking about change in service. So what we try and do is talk via patient groups that are already set up at the hospitals rather than directly talking to patients who are accessing care at that moment. So that's just one kind of nuance to that. So I'm just closing that one off. And then how will we engage with stakeholders? So we do kind of one-to-one interviews, we do focus groups, we do informal discussions. And the idea is to remain impartial as the kind of clear faculty, but take this qualitative, rich kind of qualitative data and go through, as John said, that qualitative analysis that will pull out the key themes that have been being shared with you. An example here is some qualitative data that's come out of the Clear Hospital that you're doing this project in. So, and these are actually things that have been said to us in some of our urgent emergency care projects in the past. And I think many of you who've worked in hospitals, you'll have heard these kind of things as well. They kind of, for me, they certainly resonate from times that I've worked in ED. So, for example, there are some great pathways for older patients, but these patients are more complex and take longer to assess and manage. Patients living with frailty have loads of investigations to rule out major pathologies. I don't always feel that we're doing a good job for these patients. Everything gets much worse out of hours. The support services such as frailty, transport and pharmacy all stop running. I'm pretty sure most older patients are admitted. And then finally, the ED environment does not feel like the best place to assess and treat complex, frail patients. So, having a little look at these statements, the next question that I have for you is to think about what the themes are that you think are emerging from these kind of 6 statements here. What are the key kind of messages that you think can align between these different statements? So certainly a lot about elderly care of the elderly, frail patients, pathway variation, service provision, and the challenges. Yeah. A desire to be better. I think that does come across certainly, and I think in those kind of conversations, there is a lot of drive anywhere you work in the NHS to try and make things better. But there's also often a lot of frustration with the challenge of actually making things better. Yeah, certainly. Avoidable admissions, definitely. Service level, stressful environment, absolutely. So you've got some certainly key themes, and I think certainly out of this one, frailty being a priority as what people are talking about. So what we would normally do is, having done multiple interviews, so 30, 40 plus interviews, we would take all of that qualitative data, and as you're doing here, we would go through and thematically code that data to really see what the key themes were coming out of it. With this, obviously, one of the key themes is frailty, and I think going into the next phase, which is the data interrogation, we would have an understanding about what those key challenges are, obviously with a lot of that rich data behind them, and we would choose to look at the data to either confirm or refute what's been found in the qualitative data and see what we can find in the quantitative data. And to do that, I'm going to just hand over to John, who's going to take you through some of the quantitative data for this project.
Thank you very much, Alex. So what I'm going to do, everyone, is show you a little bit of the live data of what we normally work with, just for a minute or two. And the reason it's only for a minute or two is if you give me any longer, we'll be here for 45 minutes, because I love this stuff and all of the insights that you can get out of it. Excuse me. So I'll just share my screen, go through a little bit of the... Now, can everyone see my screen? Brilliant. Okay. So I'll just go through a little bit high level of what the types of data that we look at are, and then go back to the slides to show you how this data would align with the findings that you've all found so far in your qualitative investigations. So this is an analysis of about 150,000 patients over so I think this is sort of a three-year data set. And what you're looking at here is patient flow through the ED department. And what you can see here is that people either come in via walk-in or they come in via the ambulance. And then they go to one of two sites, either the HRR site or the CRH site. And then some get seen and discharged relatively quickly, but others have multiple movements through the departments before being finally discharged, or, as in the majority of discharges in the majority or in the minority of cases, admitted. Baseline is a 10% breach rate, and 90% don't breach. Now, if we want to go back, this is the overarching view of the hospital, of the AD, and most people seem to get reasonable-ish care. But what everyone here has been looking at is the care for frail patients and want to understand how we can improve that. Now, I don't have a perfect marker for frailty, so what I'm going to do here is, and this is more for speed rather than anything else, so I'm just going to use age as a proxy. Age, as we all know, is not a very good proxy at all for frailty in any way, shape or form, but in terms of the speed of trying to use the analytics and not wanting to take time, we're just going to use age. So what I'm going to do now is apply an age filter onto the data. And what we'll see is we've dropped from looking at 150,000 people to looking at 26,000 people, which is a much smaller cohort of patients. And what we will see here, if we go back to looking at the flow, is that, and the flow takes a little bit of time to load up, maybe sort of 20 seconds or so. And that's because of there's a lot of very complex calculations that the software is performing in the background, which I pretend that I understand, but in reality don't. It's to do with relational databases and multiple different queries via the Tableau front end. But what we'll see here is a different view of how all of the more elderly patients flow through the department. And this will hopefully, this will give us a better idea as to whether or not the perceptions that staff had with their qualitative analysis are borne up in the data. Now, what you can see here is that the minority now, as opposed to the majority, are coming in via walk-ins, sort of 35%. The majority are coming via ambulance at 63%. Much higher proportion breach, 23%. And as you can see, a significant proportion of these patients are starting to have more moves through the department. So these black bars, which were fast discharges, are now much smaller, and these fragmented squiggly lines, which is each individual patient journey, are now much more in the majority. So you're having someone mentioned variability of pathways. What you're seeing here is exactly that. Increased variability of pathways with multiple different ways for patients to navigate themselves through the department, which if you are elderly, or even if you're young, but especially if you're elderly and potentially off legs and unwell, is not a great patient experience in any way, shape or form. What you're also seeing here is after multiple variable long pathways, a significant proportion of patients have been admitted and a far smaller proportion of patients are being discharged. And this is, again, sort of all aligns with what we've seen so far in the qualitative data. And what we can also do with this data is say, okay, well, if they are being admitted, or if they are coming, what are they coming for? And this data that we're going to look at here is not perfect data, it's coded data, but it gives you a bit of a feel for why most of the patients are arriving. And the way that you can do it is you can just simply select, and it says, and it tells you why most of these patients are turning up. As you can see, falls are the biggest ones, 1,200. Unspecified injuries to the head, 727. UTIs. So a lot of this stuff already at the top is the kind of things where you would want there to be pathways and procedures in place so that the patient could either not come to ED in the first place, or if they do come, they can be managed in an appropriate manner. That doesn't mean that they're in the department for, on average, 4 hours, but in practice, potentially a lot longer. I will stop sharing my screen now and head back to the slides, because as you can see, if I get talking on this stuff, I can go on all day. But Alex, can you pop the slides back up? Because you were driving them expertly before. So if we just go back to what we found from the data, key findings. 150,000 patients, overall good flow, but 50% of the patients are discharged after a short number of moves. And so when we interrogate that data further, on the next slide, please, especially for the frail patients, we can see that there's much more fragmented flow. Patients having a lot more moves through the department, and a much higher proportion are coming in via ambulance. And what this indicates is that there's room, that what's happened in the qualitative feedback is borne out in the data, and therefore there's opportunity for us to change things to improve patient care. Next slide, please, Alex. And all the things that I've alluded to are here on this slide, but it's just to sort of state that we have higher admission rates, we have higher numbers of investigations. I didn't show you on the data, but if you were to delve into it in more detail, most of these patients have a short length of stay in hospital of 2, 3, 4 days, and so that generally indicates that we could probably even avoid the admission or potentially get them out a little bit sooner. And again, we didn't investigate that in detail on the analytics, but just take my word for it, the pressures are much higher on the Fridays and the Mondays, and lower in the middle of the week, and that was associated with an increased presence of community services. I'll stop there, just in the interest of time. Oh no, I won't stop there. I'll continue to talk to you about some of the innovations that we can deliver to support patients. So, in terms of innovations, this is where you guys have, everyone has done the qualitative engagement. You've understood what the challenges are. Now you've seen the data. What's borne out in the qualitative is evidence in the qualitative. What on the next slide? What are the potential innovations and solutions that you can think of? And Suman, if you could pop up the word cloud, that would be much appreciated. SOPs. So it is frailty unit. So just on the frailty unit point, actually, in SOPs, in one project that we did, there was a frailty unit for 8 patients that was open from 8 till 4 on a Monday to Friday. And after the team at the Trust did analysis of the data, they found that there was actually space for a 24-bedded frailty unit to be open 24 hours a day, 7 days a week because of the volume of frail services. And the what this showed was that although everyone was working very, very, very hard at trying to get the right frail service for these patients, it's just taking a little bit of time to step back, look at the data, engage everybody, and that would then that would support you to relatively easily design the optimum frailty service for that department. So, a couple of other points here about long care navigators. The care navigation service, it's really, really helpful. Care navigators and care coordinators, you're starting to see these roles pop up across the NHS, both for elective care and emergency care, and they really can be incredibly helpful, especially for patients who are less technologically literate, or who have who are less access to these services, or engage less with healthcare. There's a point that's been made in the chat about dedicated space with specialist staff. I can't emphasize the value of this enough. One of the things, as an anaesthetist, I'm a little bit of a generalist, and I know a little bit about everything. And my risk tolerance for admitting patients, if I was in A&E, which obviously I go there occasionally from an intensive care perspective, but less to look after this patient cohort, would be much, much higher than someone, one of my geriatrician colleagues or specialist nurses, who would be far more likely to say, hold on, we can manage this patient, and we don't necessarily need to admit them to be able to manage their needs well. There's a point about escalation plans. I think they are something that we do a lot better than we did 10 years ago. I think there's obviously a way to go, and having those conversations in the community, I think, is really useful so that people get the care where they want to have it. Full service, again, support is dedicated full service. I think that they're most trusts have them, but they're not necessarily always aligned with what patient needs are. Diagnostics in the community, again, invaluable to have earlier investigations sooner in any disease process. I will stop there just in the interest of time, because we will run out if I keep going. But these are fantastic answers, and again, they get right to the heart of the problem. To summarize, after multiple sessions, or after just very few sessions, what everyone here has decided is that there would need to be a frailty unit for this hospital that would provide 7-day multidisciplinary service with appropriate specialist input to support early identification and assessment of people with frailty, so that they could be treated and avoid admission as appropriate. If we just move on to the next slide, please. Obviously, more work will need to be done to engage the right people, ensure that the staffing can be managed appropriately, the skill mix is right for the patient need, and the estates is available. So we haven't just finished just yet, but you can see you can get quite a long way relatively quickly. But then, excuse me, working through the data so that a really well worked up model of care that is bought into by all is imperative, and that takes a little bit more time and engagement with a group of individuals. Apologies, my voice seems to have gone, which is not the most opportune time, but a good time for me to hand back to Alex.
Super, thank you, John. So you've gone through clinical engagement, you've triangulated that with your quantitative data, and you've come up with some innovations. So the last phase of the CLEAR project is this recommendations phase. What happens then is essentially that, having come up with these innovations, you'll then go through the detail of doing a workforce model for them. So really understanding what types of workforce you will need, and the impact of the changes you're suggesting. And those changes will include estates changes, potentially process changes, workforce changes, and that all gets articulated in a report and presentation. But in order for this to actually gain the traction and have the impact that we outlined at the very beginning, we need to make sure that, having come to the end of the project, that the recommendations actually get implemented. One of the key things to making sure that that happens is making sure that we present it to the right forums and to the right people. It's obviously been engaged with throughout the process by everyone on the ground, so people should be bought into the direction of travel and should be very keen to get started with it. And we've often had to try and tell people to pause slightly in getting started on their recommendations before it's seen some more senior stakeholders. But really, to make sure that it gets proper buy-in, we then need to get the buy-in from other individuals. So this is the last question we have for you. In terms of who you think it's important to present this to get that support from. And I'm going to ask Suman for the last time, thank you, if you could put the poll up, please. The NEDs, yes, definitely. Clinical governance, trust board, executive teams. So certainly what we found is it's in order to have a successful project in any organisation, we need to have executive champions. We need to be able to get this in front of the board. We need to have that all the way through, actually, that people are involved and engaged at a board level to make sure that it gets seen at the right level to be engaged with. And certainly it is useful to also have that visibility outside of the organisation. So, as some people have said, in terms of the ICS or the ICB, understanding what's happening in the community around similar things, so that they know what's happening in that organisation, and sometimes can dovetail the work that they're doing with the work that's happening in the organisation. And that particularly has been useful not just for acute trusts, which is the project we're doing here, but also in work where we've been working with PCNs, primary care networks, where certainly in the community or in the system, the way that care is delivered in one space affects the way that the care is experienced in another. So there's certain areas where there's synergy that can definitely be used and optimized and recognized if we present this in multiple forums. So it's really, really useful at the end of the project to present it not just to those who are directly involved in the recommendations happening, but also to other organisations who may be interested in seeing how their services interface with the change here. So thank you very much for contributing to that one. I appreciate we are coming close to time, so we're going to close off probably now just with a little bit of a case study, which John is going to run you through, and then we're going to have a few minutes for questions as well, and then we will close. So John, I'm going to hand over to you just to take people through this case study.
Thank you very much, Alex. This is going to be a very whistle-stop tour of this case study, but this is a UEC project that was completed at Hampshire, and the population that was, or this project is not too dissimilar from the one that we have just gone through ourselves. The key points to make is that there was improvements that the CLEAR team, which consisted of nurses, doctors, and ambulance staff. So it was a multidisciplinary CLEAR team in the trust. And that multidisciplinary team basically came up with improvements to streaming processes, upskilling existing staff and utilising ACPs more broadly, as well as the creation of a dedicated OP older persons ED department, so that they could be more specialist input into the frailty cohort. What this resulted in was a change to the skill mix of staff, as you can see, slightly less medical involvement and more nursing and advanced care practitioner involvement in the delivery of care. And the striking thing is that this particular site felt they could prevent quite a large number of emergency admissions for frail older patients, which had significant cost savings as well as benefits to those patients from not going to hospital when they didn't need to be there. There was also benefits in terms of creating career pathways for staff to stay within ED more, because we know we have high churn in that particular department, in that particular area of care, because it's so intense and difficult. And also medical time was released. which was as part of this particular case study. I can go into more detail, but for the sake of time, as Alex alluded to, I'll stop here. But very happy to share the slides, Jess, as you've asked. And I suppose at this moment, Alex, the key thing to ask is if anyone has any questions that they'd like to go through at this moment in time.
Absolutely. So I think we'll stop sharing here. We're obviously we're due to finish at 1:45, but I think John and I can stay on for another 10 minutes. Thank you very much to anyone who does need to drop off, though. Thank you for joining us. And we'll take a few questions in the next 10 minutes for those who can stay on. And either if you put questions either in the chat or if you raise your hand, we can field them either way. I think we'll be sending out the recordings later at the end of this week or next week, probably soon, won't we? I've just seen that question.
Yeah, sorry, we'll be sending out recordings as soon as possible.
That's fantastic, thank you. Wonderful. Well, if there are no burning questions that you have at the moment, please do feel free to get in touch and ask us otherwise. But many thanks for attending today and our first session of the 2023 Clear Week. And please do sign up to more sessions and share with others if you have. Today we have another session, or our next session is on clear ophthalmology, and that's going to be this afternoon at 3 p.m. But we also have some sessions later on the week. So tomorrow we've got a workforce planning game in the morning called Wardopoly, which you can then interact with again. There's also a session about the findings from the Clear Anticipatory Care Programme, which if you're interested in primary care would be a very good one to attend. There's also a view from the front line. So that's a session with 3 NHS clinicians, which will take you through their clear journey. So a perspective from someone doing the work themselves. Then on Wednesday, we have a morning session looking at elective recovery. So that's around operating theatres and elective recovery. And then in the afternoon, we have a panel discussion, which will show how far the NHS can transform and recover services and have a good discussion around that. And then a little focus on clear mental health in the afternoon after that and findings from that programme. I think on Thursday we have some more work in primary care, so particularly looking at same-day services and improving access to same-day urgent care. And also then looking at the high-intensity users projects with East Warrington PCN. And then finally on Friday, I think we'll be unveiling our latest report on urgent emergency care, so similar to this session, and we'll be looking at how proactive care in anticipatory care is helping to reduce the number of patients going to ED. And we'll be talking to Hyde PCN about that and their work in dementia. So lots of things going on this week, so please do share, and if you're interested, sign up to those sessions. And as Simon says, we'll be sending out the recording for those. If you can't attend in person, please let us know that you'd like to look at the recordings, and we'll send those out to yourself and share those more widely as well. But absolutely wonderful to see you all, and thank you very much for joining.